that. So what I mean by that is we're working on a philosophy of extension first and then flexion gap, which I know is different from the classical fill the flexion gap first type of philosophy. But the reason we do that is because the most reproducible anatomical landmark is the epicondyle. So if you take your Romero calculation, and if that is, for example, 25 millimeters, you know that the implant thickness of 10 millimeters plus the 15 millimeters for the 15 millimeter augment cut, that sets a position 15 millimeters from that line. So if you place that 15 augment cutting slot over the tip of the medial epicondyle, you will be establishing a joint line that is 25 millimeters distal. So you then just skim through whatever augment slot you need to seat and select the actual augment you're putting behind your component. Now, a lot of people will work on the flexion first, but we, having done that distal cut, will go and put a spacer in extension. So here you can see the yellow spacer making up for the distal augment. The purple spacer is telling us the thickness of the poly, and then we take that same spacer into the flexion gap to finish off the flexion gap. Now, the reason we chose to do it this way is to do with the reliability of the medial epicondyle to the extension joint space, and the fact that the modern implant systems and their great ability to offset posteriorly allow us to fill that flexion gap. Those that go for flexion first, there is always a slight danger. If you select the wrong size femur to start with, you'll end up putting too much poly to fill the flexion gap, which then elevates your joint line in extension. Or if you ream on too long a stem, it tends to anteriorize your femoral block and implant, which again increases that flexion space and reduces the offset. So this is the way we've chosen to do it. So you start with your expected femoral size, you set the rotation, normally to parallel the tibia in flexion, and then you just check if it's seating anteriorly. If it's seating anteriorly, you just check if the spacer block fits in nicely in flexion below the cutting block. If it doesn't seat anteriorly, you have to use a posterior offset to drop the femoral component posteriorly. You keep dropping it posteriorly until either it's nice and balanced or it looks as though it's going to start notching anteriorly. If it looks like it's going to notch anteriorly, you just need to change for the one size bigger finishing block, and then that will fill the gap. You then have your trial implants in, and on the left here you can see a case where there was about 5 millimeters of bone left, 15 millimeter augment plus 10 millimeters of the implant gets you 30 millimeters from the epicondyle, and you can then also check that against secondary measures like the meniscal scar, as well as checking your stability and your patellar height and tracking. In a case like this, for example, which was already a revised case, you can see a small femoral component that's been placed too proximally. You can see reduction of the posterior offset, and you polyethylene that has increased the joint line. But you can't just stop at that planning. You've got to know that what that means is you've got to put in a bigger femur with posterior augments and with distal femoral augments. So you land out taking out the implant on the right and putting in the construct on the left to correct those parameters. So in doing this revision, we've actually been able to drop the joint line, increase the posterior condylar offset, and reduce the size of the polyethylene. We know that this system works for us. 100 consecutive lesions, good improvement in the Oxford score. And we also know in a series of over 400 lesion revisions that if you look at the scores for your first time revisions for good indications like aseptic loosening, for example, then the Oxford scores are very comparable with cohorts that you see for primary knee replacement. There will be special situations, and as I talked about, those more complex cases. So if you have a contracted or attenuated soft tissue envelope, you're more likely to need to compromise or go for more constraint. Or if you have a situation of patella baja, you need to definitely make sure you don't elevate that joint line, but you need to make a judgment call as to whether you accept a slightly low patella or whether you elevate the tubercle. And particularly that's worth considering if you've needed to do a tubercle osteotomy as part of your access approach. So in concept, we aim for that primary knee, the right size, component, the right position. Think of that measured resection principle. In terms of re-establishing the joint line, the pre-op assessment sets that target. Keep your thinking time out of theatre, that slows things down. Your intra-op validation then refines the target, and if you have that reproducible workflow, you can normally efficiently hit that target. So plan your surgery well, both before and in the early stages of surgery. Execute your structured protocol, and that should allow most revisions to be efficient, successful, and stress-free. And the reference there is from our unit, where it talks through the way that we plan and do revisions. Thank you for your attention.
Well, thank you, Mr. Porteous, and I think we're going to have some more time for questions at the end. One has come in about the joint line position, which you've covered very nicely. And I'm going to go on and share my screen and give a talk on clinical experience with a modern revision system. There is some overlap with Mr. Porteous's talk, but there's different ways of doing this for different surgeons. And I would agree with the workflow that you've seen of starting with the tibia, assessing the gaps, and reestablishing the joint line. In a primary knee, we use bone cuts to get our gaps, primarily in soft tissue releases, to balance the coronal alignment. In revisions, rather than bone cuts so much to get the gaps, augments are used. And then I think the cones accommodate a need for larger bone defects. These are my disclosures. I've been working with Smith & Nephew over the years. And as you've seen from Mr. Porteous's talk, the first step is the tibia. Once the components are removed, the endosteal referencing technique, or intramedullary alignment, you might say, in order for the stem to line up with tibial cut, means that the cutting block is placed over the proximal end of the femur in most systems, including ours, and gives a very reliable tibial bone cut, so that the height will be restored with augments as needed, depending on the amount of bone left. This is a reamer going down to some viable bone. I think it's more a sense of feel than anything else for how wide to go and how long to go. Individual choice, but generally down to the isthmus or diaphysis. The tibial cutting block is then placed over the end of this. This sits kind of medial and has places for pins. As you've seen, there's one angled one that goes in along the medial side, which is very nice. And then the intramedullary portion can be removed so that you can see the bone cut, making kind of a cleanup cut here on the tibia to just remove a minimal amount of bone. After that, I think it's helpful to get some assessment of the gaps just by distracting the femur from the tibia. These are really rough estimates, but they do give you kind of a sense of where you're starting from in terms of flexion and extension spaces and what might be needed to augment them. Ideally, we would have equal gaps in both flexion and extension. That rarely occurs right after removing the components, but that's our goal, and augments are needed to accommodate it. This is a short animation which shows that the trials are used to balance the gaps. Once the trials are placed in flexion, the tension can be assessed, which is pretty good. In this case, there's more of a gap in extension, and then augments can be added on to accommodate that. And the augments in this fashion are really used to balance the gaps more than the bone cuts. The augments move the femur distally or posteriorly, posterior offset or distal offset. And that's what I think has become the fundamental use of the, there we go, of the augments rather than bone cuts like in a primary. This situation is one that I see fairly commonly, though, after everything's said and done, where it's fairly loose in both flexion and extension. These are bigger gaps, and one way to deal with this is simply place the femoral component onto the end of the bone and then use a relatively thick polyethylene insert. The problem there is that this creates some relative patella baja, and the joint line really has not been established adequately here. It's been raised, even though the gaps are balanced with a thick poly. Alternatively, the femoral component joint line can be moved distally with the distal augment and posteriorly with the posterior augment, and then an offset stem is used to use a thinner polyethylene, and this more effectively establishes the joint line. And by establishing the joint line, the ligaments are balanced, but also the position of the patella is more normal, avoiding patella baja. In addition, the posterior offsets, as you can see here, this is a knee with flexion instability, shown with the arrow indicating the inadequate posterior offset on the left, and then with a posterior offset in the revision component and stemmed implant, the posterior offset is restored, which helps gain full flexion and also take care of the flexion instability. Bone loss has been described in a number of different systems. This is an older one from the Anderson Orthopedic Clinic, which really hasn't been updated effectively and shows three different types of defects. The one on the left is kind of a minimal defect where the ligaments are intact, and along with the bone defect comes loss of ligaments. So the smaller defect can be handled by a regular cruciate retaining implant. The center one, usually after revision of a total knee, requires stems and may require varus valgus constraint. And then when the epicondyles are lost in a more severe defect on the right, additional constraint, including a hinge, is needed. The constrained options provide a tug and groove mechanism. This is the constrained PS version, or a hinge, which has a transverse axle and is more constrained, but any additional constraint places more stress on the bone implant interface, so that only as much constraint as needed should be used, but the hinge is usually indicated when a ligament is deficient. This shows a stress radiograph of a knee with an absent MCL, and because of the complete loss of MCL, the constrained Conler type device doesn't really provide adequate stability mechanically. This relies on the strength of the polyethylene, which is really not as strong as a metal axle used in a hinge. And alternatively, when the collateral ligament is gone, a hinge is indicated. This shows the legion hinge mechanism with various parts that are assembled intraoperatively to provide the stability needed for that type of case. When the bone loss extends up into the collateral ligament origin or insertion, such as here, this was a reimplant from the spacer, then I would recommend going directly to the hinge, or at least having it available, because in many situations, it's not really clear whether or not the hinge will be needed. This shows the hinge used also with cones, and the cones have been very effective to accommodate bone defects as well as provide ingrowth. The history of the cones goes back to this type of device and publication. You can see reference, but these required a fairly large amount of bone sacrifice to get the cone in, but ingrowth did occur, and the clinical results that have been published a number of times shown here have been pretty good as far as durability of these cones once they effectively osteointegrate. The legion cones have been developed based on anatomic considerations and in order to fit the legion system and offsets. This is a analysis based on CT showing the orientation of the tibial cones, which fit the bone pretty well, as you can imagine. And the instrumentation is intended to provide an intimate fit between the cone and host bone to allow for ingrowth, with reamers followed by broaches and precise measurements to establish the position of the cone, keeping in mind the joint line. Retrieval studies of cones also show pretty good ingrowth. Now, it's not a large area of the surface. This is the same thing that's occurred essentially in all retrieval analysis of ingrowth fixation surfaces, but you don't need a lot of area in order to establish stability. One of the factors contributing to loosening of cemented stems, I think, has been the interface of the cemented revision and sclerotic bone that the cement doesn't really attach that well to. And this is a loose revision stem that was revised to another revision stem. The main difference, though, is that cones are applied, and the cones not only fill the bone defect, but also allow ingrowth and more durable fixation, which I think will extend the longevity of our revision procedures. So the evolution of the cone has been from a bone defect filler to more ingrowth. And they can also be used with shorter cemented stems, shown here, by making the bone cut and using the sizing template to orient the reamer, which is a little offset here from the center of the tibia, but rather than using a longer offset, a shorter fully cemented stem, shown in red, and cones shown in white can be used, such as in this revision, which was a loose cemented implant and revised with a fully cemented short stem and a cone, particularly on the tibial side, where the cone provides more durable fixation and avoids the longer stem and offset. So in summary, the evolution of the purpose of the augment, I think, has started from filling small defects to balancing the gaps, whereas large defects are treated more effectively with cones, and the cones also provide biologic fixation so that we can anticipate more durable longevity of the reconstruction. So I'm going to thank you for that. Again, we'll have time for questions towards the end. Let me just okay, great. We've gone on. And I'd like to introduce Dr. Wadhwa. We'll transition things over to him to talk about the 5 top tips and pearls for complex knee revision. Manny, you there?
And Mr. Porteous for setting the tone right for the revisions for me. So friends, in the next couple of minutes, I'll walk you through the tips and pearls for revision total knee arthroplasty. In the part of the world that I live in, our complex primaries are also more like revisions, and we require a lot of these facets. So I'll walk you through the flow of the events. Slides are not moving ahead. Okay, so these are my disclosures. And the workflow for the revision that we follow through is definitely walking on from the skin incision to the safe implant removal. We always start with a refashioning of the tibial platform. We try to build the femur first in flexion, and then we build up in extension. Once we have done that, we always come back and address the bone defects and augments and stems and cones. And ultimately, based on that, choose the modular implant and the kind of constraint. So friends, in the next couple of minutes, my 5 tips are going to be based on these 5 basic pearls. Number 1, wide exposure. Second is removal of implants and how do we preserve the viable bone. Gap balancing and bone defect augmentation that we heard through. The restoration of joint line and rotation alignment. And last of all, we'll speak on the modular knee system, which we have spoken of is a beautiful lesion revision system that we run through. For any case, preoperative planning is critical. Identify the reason of the failure and exclude infection. One of the biggest reasons for early cases is infection, and rule out infection before you proceed to move in for a new implantation. Now, talking of the exposure, adequate exposure is one of the keys in revision total knee arthroplasty. And when I'm going to talk about exposure, it's superficial exposure, deep exposure, and in case of need, axonsile exposures. If you have multiple scars, choose the lateralmost incision because the supply is medially dominant. avoid subcutaneous dissection, go deep to the silver fascia, and try to preserve the vascularity of the flap. And if crossing previous incisions is unavoidable, do so at 90 degrees. The arthrotomy that we normally prefer for all cases is medial parapatellar arthrotomy. And in these arthrotomies, you clear the subcutaneous tissues, the scars, the medial gutter, the lateral gutter, the anterolateral portion of the tibia. And whenever you have stiff knees or cases in which you're doing for two-stage revision or all those cases where a lot of delays happen through, your threshold for going for expentile exposures has to be low. Our favorite is quadriceps snip, but you have options of turn down, tibial tubercle osteotomy, medial apicondylar osteotomy, and femoral peel technique. So how do I approach? The basically ideology is whether you're doing it for a stage 2 or a stage 1. Keep an extensile approach, give long incisions, remove the scars in the suprapatellar pouch, in the medial gutter, in the lateral gutter, go beneath the patella. Be very, very particular that you have to retain the extensor apparatus. Do not create a rupture of the patellar tendon or the quadriceps tendon. And your threshold for rectus snip or tibial tubercle osteotomy in cuff stiff knees has to be lower. The workhorse for us for all stiff knees is initially we give a rectus snip, which is where we give an incision in the quadriceps at a 45-degree angle into the vastus lateralis muscles. It raises the extensor apparatus onto the side. We intend not to dislocate but to subluxate the patella. In rare cases where we require a lengthening of quadriceps for very stiff, tight knees, we do a VY. But otherwise, quadriceps turn down gives you a lot of morbidity onto the extensor apparatus and extensor lax. That is not one thing that is very formally recommended. If snip doesn't give you what you want to look in, then the next step has to be the distal release, and that is tibial tubercle osteotomy. One of the key things that you need to remember in mind is A, retain a bridge of bone proximally because you do not want a proximal migration of your tuberosity fragment. You would give a taper at the distal end because you don't want a fracture. Retain the anterolateral soft tissue supply and keep at least 6 to 8 centimeter long osteotomy with 1 centimeter thickness. You want to fix them subsequently with screws or SS wires is purely your choice. But if done well, tibial tubercle osteotomy is a wonderful technique to bail you out in all stiff knees, ankylosed knees, arthrodesed knees to conversion to a revision total knee arthroplasty. Safe implant removal is the key. For this, you identify the interface between the implant and the bone cement, go with the thin osteotomes or very thin saw blades. You need to have special equipment and instrumentation to have a safe implant removal because you want to salvage as much as the host bone as possible. You need to have Midas cutting tools, special osteotomes, ultrasonics, and in case of long stems, you need to be ready for anterior femoral flap and tibial tubercle osteotomy for difficult stem extractions. You need these kind of special equipments to take out your implants, salvaging as much of the host bone as possible. And remember that you have to walk with patience because you want to leave the bone in the patient, not on the implant. This gap balancing techniques has been discussed in detail by the previous speakers, so I'll try to walk over it. Bone defects. So it's basically the type 1, 2, and 3. In type 1, you have localized defects, but the cortical rim is intact. You can easily walk off these defects from a CR to a BS and the joint line is retained. You only require some set of bone graft or bone cement to get across these deformities. When you have a class 2 defect, where cortical rim is intact, but you have a loss of metaphysis, this is a case where you require specialized augments, stems, in certain cases, sleeves to bypass these defects. Type 3 are the main defect pictures where you have a loss of condyles, a total loss of cortical bone. And this is one case where legion, rotating hinge, your metaphysis sleeves, your cones definitely have a space. So whatever you require for fixation of your revision cases, you have to have an armamentarium ready with you in consideration to the blocks, wedges, spacers, cones, sleeves, because depending on the kind of defect, you need to understand, studyify what is the kind of coverage you need. For a tibial augment, you have this kind of hammy wedges, the step wedges. But before putting in cavities, the caveat that you need to remember is whenever you have to put a wedge, first make sure your tibia is absolutely in alignment with the femur because you cannot afford to have a malalignment between the tibia and the femur. Always use a stem if you're using a wedge, and bigger the augment, the longer the stem. Femur also has this kind of distal and posterior augments. You need to augment it through. And whenever using augmentation, Remember, distal augmentation for femur is more important than posterior augmentation, because we understood we have to retain the joint line, and transition of the femur is actually what is the requirement. Now, the next step, apart from these augments that you have or need, is the stems, which are increasingly being used in complex primaries and revisions. Also, the need for sleeves and cones in mainly the revision cases. Stems are definitely required in revision cases to offload stresses from deficient bone to protect your fixation interface, and a necessity in almost all revision cases. The controversies when we go to the stems is whether I should a cemented or an uncemented, long stem or a short stem, straight stem or an offset stem, because different kind of situations dictate different parameters. Our recommendation these days is to use a hybrid fixation technique, a press fit stem with cement only in the first 2 to 3 centimeter area, so that you have a good hold, but at the same time you don't cause a tip pain, and you can easily have a re-revision required through. In a couple of our cases, especially in our countries where you have a lot of bowing, is the need for offset stems, not only for the tibia, but both for the tibia and femur. It allows you optimal implant position, and they're designed for optimal proximal tibia and distal femur coverage with anatomical stem placement in the medullary canal. So you have a beautiful control of systems. You are not proud and making your extensor apparatus tight. In the tibia also, you can use a wide optimal tibial coverage with good control into the intramedullary canal. So to conclude on these augments, metal augments are best combined with the use of intramedullary stems. Our favorite these days is these kind of slotted stems with flutes, press fit stems, and the need of augments. In complex type 3 defects in revisions, the metal sleeves and cones are definitely finding a big space, like we were showed about the legion cones initially. So these are the things to augment when you have a big, huge defects in the metaphyses and in the distal cortical areas. So these are alternate to huge allografts, and allografts have their own downsides of disease transmission, graft incorporation, the source of allografts. So these are biological fixation at the interface and give you a very good hold and a very good capture for your complex revision cases. These days, the new metaphyseal cones for the tibia as well as femur are a good solid foundation for the implant. Sleeves are used for defects, especially after stage 1 revision. We get a lot of these kind of stage 1 cases in our countries where you use these kind of metaphyseal sleeves to have a good capture control into the metaphyses and along with stems. The beauty of a sleeves otherwise is that many times you can even use it without the need for stems, and many times you don't even require the offset. Structural allografts also have a special space. You need to have femoral heads, distal femur, proximal tibia, or an extensor mechanism dysfunction. Many times you require extensor mechanism grafts also. So the key that has been explained to you is please retain your joint line. For doing that, in extension, you need to distal femoral augments, and to maintain, as Dr. Engh told you, to maintain the flexion gap, you need to retain the posterior condylar offset. There were questions in the chat box about clues to anatomic joint line restoration and to know in a revision. There are multiple markers you can use, as was explained to you on the trans-apicondylar axis width, and in relation to that, the position of the medial apicondyle as well as the adductor tubercle. You can have a marker on the lateral apicondyle, the tip of fibula, the lower end of patella, tibial tubercle, or multiple things in combination you want to use through. These are examples where you have a patella baha, the joint line is not respected, it's a proximalization of joint line, and ultimately you will never have a happy patient. So these are again cases in which the joint line is not respected, the patella is going lower to the joint. So the maximum cases of proximalization of revision of joint line in revision arthroplasty is where you have a distal femoral bone loss, you have a large flexion space, in cases of revision knees with a huge amount of flexion contractures, and in all those cases, you need to use grafts. Distalize the joint line by using in distal augments, maintain the posterior condylar offset by using the posterior offsets. Femur rotation in a revision case is again a very important part to remember through. Here, your posterior condylar axis does not exist. The markers that you take in combination is your AP axis or the white size line, trans-apicondylar axis. And like in our case, we try to build the tibial platform first, and our rotations are also based in a big way as sync and parallel to the tibial cut. So depending on the kind of implant you have through comes the choice of the right kind of implant. You can choose a PCL retaining in a very beginning case, to a PS design, to a semi-constrained, to a hinge which is linked or unlinked, or a rotating hinge. So these are different kind of parameters depending what is the kind of constraint you're using in. But always remember, these kind of global instabilities, the coronal plane, multiplane, sagittal plane, recurvatum deformities will require the need for a hinge on table. And the unremembered or the forgotten sort of interface between this tibia and the femur is the patella, which is missed. But in a revision case scenario, you should remember to either retain the implant, which is a very much a possibility. We accept even if there's around 25% of cold welding, you might decide to revise the implant to remove it through rebuild or doing a gullwing osteotomy, or in cases where you have a loss of extensor apparatus, you replace the entire extensor apparatus. So the key to remember is no thumb technique as you do in a primary. Your patella has to sit very well into femoral sulcus and avoid extreme joint line elevation. There is definitely a place for rotating hinges in all these kind of complex salvage procedures in old elderly patients, but in any younger patient, try to preserve the joint, try to preserve as much as the host bone and least the least amount of constraint that is possible. So the key to remember is use an implant with minimal degree of constraint necessary to solve it through. Most of the time, stability will be achieved by either a PS or a varus valgus constrained knee. Only occasionally on table you require a hinge, especially in cases of MCL deficiency or very wide, huge flexion gaps. So whenever doing a revision, I go back to the same parameter. You should know the reason why you're doing a revision. Do not do a revision purely for an unexplained pain, and don't revise too easily the patient of another surgeon. And remember, there's nothing so bad that can't go worst. So the take home message from this talk is understand where you can go wrong. There are 5 steps in which you have to be very, very cautious, and decisions are at times more important than incisions. So you do not want to create pictures like this for future if somebody comes in and has a terrible time to do a re-revision if required through. So take your decisions well, understand the fundamentals and the basics for revisions. Do it supervised with a mentor in the beginning, and I'm very sure that subsequently you can do a huge bulk of revisions, which is going to be the flood that's going to come in the future. Thank you so much.
Okay, well, thank you, Dr. Wadra.
Yeah.
And at this point, we have some time for questions, and we've had a number of interesting questions come in, which I'd like to pass around to the panel. I've been going through some of these, and be interesting to get the participants' response. But one of them was, what do you do if you have to revise an implant with cones? Fortunately, that hasn't happened too often with me, but it's kind of difficult to get these out, and they can be associated with considerable bone loss. Dr. Wadwa, do you have any tricks for getting the cones out?
So not really. I mean, the stage has not come in so far that we have to take out any cone in our patient. But theoretically, I think you need to have a Midas with you, a very fine cutting tool to go around the cone to relieve that.
Okay, Andrew, any other advice?
So we haven't had a lot of cone usage historically to see those needing to be removed, but we have over time used some sleeves. And with the sleeves, it's often only the proximal centimeter or so of the tibial component that has a coating. So often you can just undermine the tibial plateau, knock that out, and it uncouples from the sleeve. And then just going around with an osteotome that proximal centimeter, and then it comes out on the tibial side at least. With cones, it is more destructive if you've got a fully cemented stem and a cone in there. And then you need to plan to have an option of a sort of a distal femur or proximal tibia available, because it can be a very destructive procedure getting those out.
Yeah, I'd agree with all those comments. I think there's a fair amount of unpredictability, and it's useful to have everything you think you might need to reconstruct the femur after the cone comes out if it results in more bone loss or a pericosthetic fracture. A couple other questions that we didn't fully cover because these are sort of beyond the scope of our presentations, but one was how to treat infected total knee with loose implants. And for me, this pretty much always means a two-stage revision, but I know some of the surgeons across the way and in other parts of the country have had good success with single-stage revisions. Are either of you two doing those?
So we do single stage sometimes, although I think our workhorse is still the two stage, and we would tend to select the single stage for a known straightforward organism, and one where the reconstruction is not going to be a massive procedure. So we do select some of our easier ones, if you like, for a one stage, although there is a reasonable philosophy for saying do a one stage in your very old frail patient rather than putting them through two episodes. Our favored one is still a two stage, although one stage is certainly becoming much more popular in the UK.
And are you doing the re-prep and re-drape the entire procedure as really described in the literature now? I think with betadine irrigation and then getting all new instruments for the second stage of the single stage procedure.
So I do like to close do a temporary closure and wrap up, change the drapes because it's often looking a bit like a battlefield at that stage. But I know some colleagues who just change the instruments that they're working with, and it doesn't seem to affect the outcome. But certainly I feel happier with at least re-draping and re-scrubbing myself.
Manny, any other ideas? You do anything differently?
See, our workhouse out here is a two-stage. One stage is strictly in the parameters where we know and we have identified the bug that is there. We have a strong host response. And if you have to do a single stage in particular cases like this, the protocol is that we would change the drapes, we would re-scrub again, a new set of instrumentation come in, and there's a new set of electrocautery about suctions, and everything is changed across for any new implantation. And in any one stage implantation, as the gentleman has asked in, you need to be sure that you have identified the bug. You have at least 4 to 6 weeks of IV antibiotics to be covering on, because you don't want this arthroplasty to fail.
Okay, we've got a question about removing well-fixed cemented stems. And, you know, I think this is a challenge for anybody. Anytime you look at that pre-op x-ray and you see a lot of cement, I get concerned. I'm never sure exactly how the case is going to go, but I'm generally prepared to do tibial tubercle osteotomy. Any other tricks, or what do you do on both the femur and the tibia? Dr. Wadhwa, it looks like we're looking at you, so how about if you start us off?
So, in this part of the world, you get knees with a huge amount of cement shoved into the primaries. That's not a rare indication for us. As far as possible, for the femur side, we would still like to work within the bone and use long special cutting instruments, thin osteotomes, to take out the cement and not to do an osteotomy for the femur. Considering the tibia, my threshold for doing a tibial tubercle osteotomy will be low. If I find a lot amount of cement that going into the canal and filled around the metaphyses, we would do a tibial tubercle osteotomy, take out the entire cement and bypass it with a stem going longer than the osteotomy. But when it stands onto the femur, we would still like to work from inside and not to do an osteotomy, because building those bones becomes really tough for our kind of patients.
Okay, Andrew, let me modify this question a little bit, because I think Manny summed up the way to get them out pretty well. But a lot of times, the question comes up: how much cement do you put on the stem when you're putting it in a revision? And when our fellows ask, I tell them that well, it depends on how close the doctor is to retirement. If he's new in practice, he puts just a little bit of cement under the plateau. If he's in the middle part of his practice, he cements halfway down the stem. And if he's going to retire within the next couple of years, he cements all the way to the tip. What do you do?
So I think we take the view that if you're doing a cemented stem, it's a properly cemented stem like a hip replacement. So we use a restrictor, we pressurize it, we cement it, and we keep our fingers crossed we never have to come back. For the majority of our easy revisions, we're using hybrid fixation, and we'll cement sort of down to and around the coupling with from the implant to the stem, or around the offset coupler. So around that sort of distance, about 3-4 centimeters down from the joint, if we're doing a hybrid fixation. If we're doing a press fit or hybrid fixation, we won't put any cement around the stem.
Okay, that sounds good. Just to change gears, we've got a question about patellar tendon reconstruction. So unfortunately, when the patellar tendon is, you know, you're doing the revision and you go to finish up and you look down there and the patellar tendon is detached, it's a kind of a sinking feeling, but, you know, one that occasionally is a reality. Do you have anything available in the OR or in your hospital to take care of that, or a preferred technique, Andrew?
So we do keep some of the mesh on the shelf. The one we use is the one from the Lars ligament, synthetic ligament system, but I know some of the hernia meshes work as well. We tend to also, in the UK, our guys that do revision knees also do ACL reconstructions. So often if the quality of the tendon's not good, we'll be harvesting hamstrings as part of the sort of biological reconstruction of it as well, because that's a technique that we'll do regularly with ACL reconstructions.
Well, at least the the mesh, you know, the hernia mesh is something that general surgeons have around, so it's in every hospital, relatively available, at least in our system. How about in India? Do you use the mesh or rely on autogenous tissue for that situation, Manny?
I think the blessing is that if it is an in situ and you can identify that's a fresh case, we would always go back to the intraosseous repair as well as augment it with the biological semitendinosus graft. And this mesh is always available in the OT because of the general surgery requirement. So we always augment a mesh on top of it. I think that's the same story out here also.
I think the one important thing though is if you're going to things like distal femur or proximal tibia, which are often the ones that have an extensor issue, you can't purely rely on mesh. You need to have some tissue there as well. So whether that is by bringing in a gastroc flap in those sorts of cases, or whether it's trying to bring in some tissue or something, you probably can't rely on a synthetic reconstruction.
What about the post-op protocol? Arlen Hansen has recommended a full 12 weeks of localization. And, you know, if the knee gets stiff, the knee gets stiff, but the extensor mechanism works. I think it's hard to tie people up for that long, but, you know, I found that anything less than that results in stretching the extensor mechanism reconstruction out. Are you both extending your post-op immobilization that long after this type of reconstruction?
6 weeks. I immobilize them for 6 weeks, and then 10 degrees every week is a protocol, 10-degree bending every week to be enhanced.
Yeah, I think if you follow them,
go 6 weeks.
Working way. Yeah. Okay. We have another question going back to the cement removal. We've talked about removing, you know, well-fixed cemented stems, but this seems to be a popular area of interest among our audience participants. And a question comes up about femoral osteotomy. As far as I know, femoral osteotomies have been described, at least in presentations. I'm not sure about the literature. And I've always been kind of afraid to do it. I've done plenty of tibial tubercle osteotomies, but on the femur, I'm not sure what I would do after that, and have found windows more effective if I need to get up there to get cement out. Have either of you done a femoral osteotomy where you took the anterior cortex off and then put it back on afterwards?
So I have done that probably 3 times, but it's something where I do just take a wedge rather than taking off the front half. It's a sort of quadrant off the front surface that you can then click back in and cable around afterwards. So trying not to take away as much of the structural strength as you can.
With the windows, I find, you know, a similar thing. You can actually just use the burr to make windows, so it's kind of atraumatic. Going to the tibial tubercle osteotomy for fixation, question about putting the wires in the front or back of the tibial stem. I don't generally put the wires around the back of the stem. I put the stem in and then close the osteotomies and tie the wires over medially because you hinge it medial to lateral. I know there are different ways of fixing the osteotomy, but it seems like when people talk about the osteotomy, they kind of emphasize how they do it, not how they close it. And I think this is a great question about how to repair the osteotomy. Andrew, when you do your osteotomy, how do you repair it? Do you screws or what?
For me, there are two types of osteotomy. The one is just for access, in which case we do a low energy, keep the lateral soft tissues intact, in which case your fixation can actually be minimal. So in those ones, we just do 3 transosseous drill holes and tie it down with a number 5 Ethibond suture, because you're just closing the book. There's no proximal migration force on it, if you like. If you're doing a more extensive osteotomy for Baha, where you're going to try and elevate it, you've got to release some of that lateral soft tissue, and it's then much more unstable. And in those ones, we tend to put a proximal step on the osteotomy. We tend to cable or screw, if we can get this around the implant, and we slow down the rehab. But purely an opening closing book for access, we don't restrict the post-op mobilization, and we just use 3 transosseous sutures to hold it back.
Any other comments on your end?
So there are 2 kinds of tibial osteotomies we run through, as Dr. Andrew said. The one is the tibial crest osteotomy, which is closed with these number 5 Ethibond. Second thing is the tibial tubercle osteotomy. And this tibial tubercle osteotomy moves around with screws to be fixed in as a priority. In certain cases, we use wires, but wires go from the back of the stem.
Well, I think I'd agree with all that. I think they're very useful techniques, and probably secure the osteotomy, minimize soft tissue irritation. I know that we're reaching the limit on our time, and hang on, let me just check one thing. I will just take an opportunity to thank our panelists and also our participants from the audience. Just to let you know, there's about 600 people out there watching this thing. I hope you've enjoyed it and got some benefit out of